to be participating throughout the meeting, and she has been a long-term friend, kidney transplant survivor. We've been through so much together, and I considered her a wonderful advocate in the kidney community, and a little bit crazy, which I think is important when you have kidney disease. So she's always quick to laugh and send me a funny joke or make somebody feel better. So please welcome Cher Thomas.
Hi, everybody. I'm glad to be here, and I'm especially glad to introduce our last presentation of the day. It is Mary Jo Godinich, who is a board-certified nephrologist on the Texas Gulf Coast. She's actually been a guest of Lori's recently on the Kidney Talk podcast, pain meds, how they work, and safe alternatives. But today she's going to be talking to us about hypertension, which is high blood pressure. Dr. Godinich.
So this topic, and we'll be presenting, my blood pressure is through the roof, what to do. So I'll be presenting this topic, and then at the end of the short presentation, I will leave it open for questions or answers or other discussions by anyone who has anything that they would want to have clarified or have their questions answered. So my blood pressure is through the roof, what to do? So the first thing to understand is if blood pressure is out of control, don't panic. Panic in and of itself is not going to correct blood pressure. It is not going to help because sometimes the blood pressure is going to be driven higher up and is going to be a further roof by the sheer thought that this is well out of control and something bad is going to happen. And also the consequences of uncontrolled blood pressure are not necessarily immediate. So you do have time to think about what's going to happen when the blood pressure is elevated and what to do. So the very heart of this discussion is come up with some immediate plan when the blood pressure is not controlled. So I'm going to ask you, the viewers, if this is your problem, that sometimes you have uncontrolled blood pressure or your blood pressure is not where you want it, or more often than not, your blood pressure is not controlled, then what you need to do to get the blood pressure under control is to somehow formulate a plan. That plan should not occur when you're in crisis situation. The blood pressure has kind of been a little bit high, and then it has gotten higher and higher, and now you're at crisis mode. The plan for an uncontrolled blood pressure is at the very beginning when the diagnosis is made. So I recommend individuals who are interested in keeping their blood pressure under control, use this presentation, use this 15 or 20 minutes, because the presentation is going to be short, formulate some sort of plan. The plan is not going to be the same for everyone. The plan will help steer you through crisis situation. So formulate a plan before there is a problem. In formulating the plan, there should be very specific parameters, and this plan should absolutely involve your healthcare provider. So you should not be doing this plan in a vacuum that, oh gosh, you've come up with something, and then you're going to implement. The provider must be engaged or involved with this sort of plan for you to have the most successful outcome. So formulating a plan before there is a problem. It is almost a unique concept in our current culture to have some sort of plan before a crisis. Mostly in our world these days, individuals are reactive rather than proactive. I love Lori and the Renal Support Network, because in the many programs of the Renal Support Network, there is always a focus of taking charge of your life, being in control of that. So I would recommend to everyone to be your own best advocate. And I'm going to come back to some details with that a little bit later in the presentation. Be your own best advocate and be proactive. This discussion of formulating a plan can occur with any of your providers at any checkup. And if you are already on dialysis and your blood pressure is not where you think it should be, this discussion can happen at any dialysis session, either with the nurses that can pass it on to your physician or other provider, or it can happen directly when your physician comes around and rotates or rounds on the dialysis patient. Formulating a plan, there needs to be very specific parameters. So it's great to have a plan, but what you're really looking for is details. For example, how high should the blood pressure rise before I'm in trouble? So you should determine that early on in the plan. How long can I put up with the blood pressure, or how long should the blood pressure be out of control before I do something about it? And then what medications can I use that I have to help better control the blood pressure or bring it back down to normal? So these are the specific parameters we're going to discuss, and this is really the crux of the talk. Specific parameters involve how high, how long, and what med. If you can keep that in mind, then you can develop a plan that'll work for you. So formulating a plan involves care providers, and we're going to discuss that a little bit more in the program. Maybe 10 years ago, 15 or 20 years ago, if the question was, my blood pressure is through the roof, what do I do? Someone might have told you, well, by all means, call your healthcare provider. As many of you know out there, if you call your healthcare provider this day and age after certain hours or even during working hours, you won't necessarily discuss anything with any provider in any timely way that will give you the information you need to make a decision. This is why you need to formulate a plan before there is a crisis. And the good news is that you can formulate a plan with any of the individuals that help provide care for you. So in the nephrology world, you see your nephrologist maybe more often than anybody else, but you may not have a good relationship with your nephrologist or as good of a relationship with your nephrologist as, say, a nurse practitioner that you work with often to address your primary care needs. There's likely a primary care physician that may be a long-term family physician that you trust more. And oftentimes in the dialysis world, the kidney patient is followed by a cardiologist. So in formulating your plan, you don't have to use just one person. You can use a couple, or you can use or pick a provider and use the provider that provides the best relationship with you and someone you can feel comfortable in discussing your issues with. So the question is, first of all, before we talk about the details of the plan, is in hypertension, what makes a normal blood pressure? This has been a discussion that's been going on for about 30 plus years, maybe even 40 years. What is a normal blood pressure? A long, long time ago, we used to say it was the age of the patient plus 100. So you would think that in 70 and 80-year-old individuals, the blood pressure could be very, very high before we would have to address it. Now we use fairly consistent standards. The American Heart Association guidelines for 2017, which are fairly commonly used across the board as standards of blood pressure, say that a normal blood pressure is less than 130/80. In the European Society of Cardiology says it's a little bit higher at 140/90. And just like in the previous slide, where if you're calculating BFR and you're using creatinine and cystatin C, that the best value is the average. Maybe the best answer in this case is somewhere between 130, 140/80/90, depending on some clinical situations and individuals' response to lowering blood pressure. So the reason we like to control blood pressure is because there can be end organ damage or detriment to the patient if we don't control blood pressure. So the type of organs that are often affected by uncontrolled hypertension are the eye, and there can be retinal damage and bleeding in the back of the eye that occurs with a significant blood pressure or fluctuation in the blood pressure. A stroke is a common end organ problem, so there can be that cerebral or brain damage. Over the long term, the heart can also be affected by uncontrolled blood pressure. And the problem that occurs in the heart isn't the same as having a heart attack or the coronary artery disease that occurs with the chronic kidney disease patient, more of heart failure, where the constant pressure that the heart has to pump against tires the heart, weakens the heart muscle, and the heart itself fails and becomes, lack of a better term, tired of pumping against the pressure. Most important damage, though, with uncontrolled hypertension occurs in our world, and that would be kidney disease. Chronic kidney disease, if it exists, will advance at a faster rate if blood pressure is not controlled, regardless of the cause of kidney problems. So if there's a primary kidney disease, like some of the odd diseases like segmental glomerulosclerosis or membranous glomerulonephritis, those diseases will progress faster if blood pressure is not controlled. And in the end stage, and in the chronic disease population, if blood pressure is not controlled, it will lead to progression to end stage renal disease faster. So that's why we as nephrologists are intricately involved with hypertension.
Dr. Godman?
Oh, yes.
Go ahead,
I can't
Laura.
see you. I can only see my screen, so I know you see me, but I can't see you. Yes, yes. So first of all, so the questions are: how high should the blood pressure rise? How long should you leave the blood pressure uncontrolled? What medications are going to be useful? Okay, next slide. So the way we want to formulate a plan, once again, is before there's a major problem. You don't want to be having such high blood pressure that you develop chest pain and you need to seek emergency room attention and you can't even think straight because there's this panic that has set in. You want to know what those specific parameters are, and then you want to involve the healthcare provider. Next slide. So in formulating a plan, the first thing that I would recommend is that you advocate for yourself. And what I mean by that is to invest in your own health. There are a number of recommendations that are currently available and out there on the web very commonly to help control blood pressure in patients who have serious blood pressure problems or not so serious blood pressure problems. So these recommendations are the universal recommendations for all patients with hypertension. They involve salt restriction, weight control or reduction if needed, exercise daily, which is optimal, but I'll take any exercise on any day. Limiting alcohol consumption, limiting fluid intake if you already have volume problems with swelling or volume control, and regular home blood pressure monitoring if you're hypertensive. Let me just say, as a physician who works all the time, that nothing makes me more unhappy than to receive a telephone call on Sunday evening at 5 o'clock after a patient has been to their cousin's birthday party all day long that involved Mexican food or Mexican food restaurant. They already went through their chips and salsa, their couple of margaritas, their cheesy enchiladas and beans. And then call me at 5 o'clock on Sunday to say, my blood pressure is not controlled. What do I do? I mean, my first response wants to be, well, don't eat all of that and limit the sodium intake. So you just already had enough sodium to last for 2 to 3 days. So let's not do that. And it's already too late. But what I'm asking patients to do all the time is to advocate for yourself. Do everything that you're supposed to do to make sure that you have followed the optimal treatment for your diagnosis of hypertension. Then it makes formulating an additional plan for the blood pressure that becomes difficult occasionally more realistic for what your needs are. If you're consistently not performing these basic measures, it becomes more difficult to formulate a plan that is reasonable as an emergency situation. Next slide.
It is the next slide. I went ahead and
oh, thank you so much. I see it. Thank you so much. So be proactive. Don't wait for your healthcare provider to say, okay, now we've taken care of your blood pressure. So in case of an emergency, this will be our emergency plan. that really won't happen very much. The healthcare provider is often distracted with other issues that involve trying to meet all of the current demands for whatever your diagnoses are. So we're always trying to meet standards of care, or should be trying to meet the standards of care. So thinking about those extra things won't necessarily occur at a visit, especially at the visit before you have a problem with the blood pressure. So it would be nice for you, and it would benefit you to prompt the physician at a clinic visit to say, I need to talk about my blood pressure. And even if it's normal, I need to talk about my blood pressure and what that plan would be in the event that my blood pressure becomes less than optimally controlled. So I don't end up in the emergency room on a Friday night when everybody and their grandmother is in the emergency room for various issues. So use any office or dialysis visit to do this. Right. If you have trouble remembering things, I recommend to all my patients, keep a notebook of things that come up, things you may or may not remember while you're shopping or while you're doing things at home that you want to bring up with your provider. It's very hard for you as a patient to remember, oh, yeah, I need to remember to ask my doctor about this. And when you show up without a notebook or a list of things to discuss, the first thing that's going to happen is your mind's going to go blank. And then the physician is going to go through their script, which doesn't necessarily meet your direct concern. Next slide. So in formulating a plan, click it, Cheryl. How high, how long, what meds? So those are the basic things that you want to know when you're formulating a plan. Next one. So the first question is, how high of a blood pressure? And click it a few more times, Cheryl. How high is the blood pressure when it's too high? Should you be concerned if blood pressure is 100 and when the blood pressure goes from 110 to 140? Well, in certain individuals, if the blood pressure is always 100 or 110 systolic, then it goes up to 140. That may represent a significant change. Every patient is not going to be exactly the same, so that the treatment plan is a one treatment plan serves all patient kind of phenomena. That's just not going to happen. The art of medicine involves taking the major literature that says we need to keep your blood pressure at 130/80 and changing it across the board to the patients that may have heart disease compared to the patients who don't have heart disease, or patient who has significant chronic kidney disease and is in stage 3 or stage 4 compared to the patient who has stage 1 or stage 2 chronic kidney disease. So a change in 110 to 140 may be important for a 28-year-old woman who prior to that has had normal blood pressure. It may not be so significant to someone like me who's had blood pressure problems for a number of years, and I'm having a rough day at the office and my blood pressure is sitting at 140 today. That would not be the same thing necessarily as having a blood pressure of 200 to 220. A dialysis patient who never takes their medication and is always sitting around 180, 190, comes in with another 5 or 6 liters of fluid overload. The difference between 200 and 220 is not going to be the same significant difference as somebody whose blood pressure is usually at 100 or 120, and then floats up 210 or rockets up 210. So what in formulating how high is an abnormal blood pressure, the individual patient needs to know when they're controlled, what their usual blood pressures are, and what would be not tolerable for them. Next issue is in formulating a plan is, how long do I let my blood pressure be abnormal? Click it a few more times, Cheryl. Is it 8 hours? Is it 2 hours? Is it 30 minutes? Is it 3 days, or is it 3 months? Back one, Cheryl. This is the more interesting kind of issue, is that some patients who are troubled with their blood pressure will wait, one more, Cheryl, will wait approximately, 1, 2, 3 months, and they'll say, well, I was just waiting for my next visit. My blood pressure has been 170 since I last slept you. That is less than helpful if we're really working at getting the blood pressure under control. Sometimes for certain individuals, if they have had generally well-controlled blood pressure, but they went out and had their salty meals, Chinese food, their Mexican food, or they were just crazy with the salt shaker, then the blood pressure for 3 minutes, an hour, 2 hours, 8 hours may be all that they're willing to tolerate. So that length of how long is too long should be determined by the individual patient or with the help of the provider, so that you don't sit on an elevated blood pressure for 3 months waiting to see the physician and then saying, oh, I guess, yeah, maybe I should have called sooner and we should have done something about the blood pressure. So have some sort of boundary or parameter in terms of how long would my blood pressure be uncontrolled before I said, last medication you gave me doesn't work, or I need more blood pressure medicine to get this under control, or I need to do something different to keep my blood pressure under control. Next slide. So these are the various medications. This is by no means an all-inclusive list of blood pressure medications. These are relatively the popular medications that we're using currently in the various classes of blood pressure medication. Determining what next medication you're going to use to bring down blood pressure that is difficult to control or to quickly bring down blood pressure. One medication doesn't fit every patient. All medications don't work the same, hence the several different classes of blood pressure medications I've listed here. So medication in the calcium channel blocker class, for example, amlodipine is commonly used for blood pressure, is a long-acting medication. It's dosed once a day. So the medication generally gives a sustained action throughout the course of a day. It would not be the optimal medication used in an urgent or emergent situation. In the same sense, ACE inhibitors and ARBs, and ARB stands for angiotensin converting angioreceptor blocking agents. These medications tend to control blood pressure not as well or as aggressively as other blood pressure medications. They are very beneficial to protect end organs like the heart and the kidney from the effect of sustained hypertension, are not useful in dramatically reducing blood pressure. So again, it wouldn't necessarily be used for an urgent situation in which the blood pressure needs to be reduced over a relatively short period of time. Diuretics like furosemide and hydrochlorothalidone is often used in the dialysis in the chronic kidney disease population. Hydrochlorothalidone can be used early in stage 1 or 2 chronic kidney disease, but it loses its effectiveness over time. And furosemide is often taking its place in the stage 3 and stage 4 chronic kidney disease. And as you know, in the dialysis population, diuretics are just not effective. So that would not be an effective means of trying to control blood pressure at all in the dialysis population. Beta blockers serve a role in controlling blood pressure. Sometimes they are used to urgently reduce blood pressure. They're very effective in protecting the heart from the effects of high blood pressure and also control blood pressure. So they can be used in the short term or the long term to help control blood pressure. Medications like hydralazine in the vasodilator category can be used acutely to help bring down that blood pressure. And clonidine has been a decade's favorite to help bring down elevated blood pressure in a relatively short situation. This is the most important time to consult with your provider in order to find a suitable medication that would be used to control blood pressure in an urgent situation or in a situation where the blood pressure really hasn't been controlled for a prolonged period of time. Next slide. So formulating a plan, it is very important to involve a healthcare provider. The emergency room should not be the first line provider for a patient. Again, if anxiety or if panic level is too high and the blood pressure is too high and any type of plan that you formulated is not working, by all means, go to the emergency room. Please do not have an adverse effect because you really want this plan to work and the plan should work and isn't working. The emergency room is exactly that. It is an emergency department for these kind of problems. It shouldn't be used as a clinic. It shouldn't be the first line of oh gosh, my blood pressure hasn't really been where I want it to be. Let me go visit the emergency room. Some patients use the emergency room for their primary care provider rather than using the providers that are on hand. The reason an emergency room is less than optimal is even if you have all the toys and tools to get the blood pressure down, they don't know enough about you. They don't really have an established relationship with you unless you're a frequent flyer and arrive at the emergency room all the time. So their time is not going to be utilized in developing a long relationship with you, finding out what has worked or hasn't worked for the last week, month, or years. So that's less than an optimal situation. Instead, you should utilize the that you're likely seeing, the nephrologist, the primary care doctor, the cardiologist, and or if those individuals are not as suited as a nurse practitioner, you should use the nurse practitioner. Anyone who's going to visit with you, talk to you, go over the history of what you've used for blood pressure, what's worked, what hasn't worked, and help you develop a plan. Next slide. So the most important things to do when your blood pressure is through the roof is formulate a plan. That's early before there's a problem, and then follow through with that plan. We'll have a step-by-step kind of process. That will help you yourself, and that will help your provider know what to do in the next scenario or how to better to protect you from having to go to the emergency room. And that's all the slides I have. So I'll be happy to entertain any questions at this time.
Super. So we do have some questions in the chat.
Oh,
and so the first one is I have taken Ramipril 2.5 milligrams to help my kidneys and to control blood pressure for about 7 years. Recently, it has caused my GFR to go to 16. When I stopped the Ramipril, GFR went to 20. Blood pressure has been steady around 110/70 with or without Ramipril. I have been advised to continue with the Ramipril in spite of the reduced GFR. What is your perspective of this?
That is a very good question, and it is a very technical question, whether you realize it or not. My response is this. ACE inhibitors are great medications. In our world, we have been recommended to continue using these medications to prevent the progression of kidney disease, even when a patient progresses from stage 4 to stage 5. There is, because there's still benefit of this medication in protecting the heart from the effects of hypertension on the heart. In saying that, what you're seeing with the Ramipril is part of the physiology of how it works. So blood goes to the filter unit of the kidney, so blood is coming this way, and then blood goes out of the filter unit of the kidney. So there's this pressure over this filter unit. When we use medications like Ramipril, it reduces the artery of the kidney, it reduces the pressure. So there's still this pressure over here. There's not this pressure over on this side. And with the reduction of that pressure, the GFR can go down. Sometimes that is a temporary effect, and sometimes it is a sustained effect. So it really speaks to the physiology of the medication. So there is a relaxation in the pressure across those filter units. And when there's advanced disease, there's reduced filter units. So you see the reduction of that pressure in a way of reduction of the GFR, as you're seeing in your case. So the answer is really fairly neutral. There are benefit issues, and in your specific case, there are detrimental issues. So it's a neutral response. There is, in my opinion, would be no harm in either continuing the medication for those benefits or discontinuing the medication, because your primary concern, I think by the question, is in the preservation of the GFR at the end, where a few extra GFR points will keep you off dialysis. So if you're more comfortable in removing the medication, for not only the preservation of those last GFR points, but your own mental health as you worry and are concerned about this, then by all means speak to your provider about removing the medication and providing something else.
Great answer. Thank you. How about what is chlorothalidone?
Chlorothalidone is a hydrochlorothiazide like diuretic or fluid pill. And what do I mean by that? So HCTZ is a very common thiazide diuretic. Chlorothalidone is similar, and it's often called a thiazide-like diuretic. In fact, in the major studies that showed that medications like hydrochlorothiazide helps with blood pressure independent of its effect as a fluid pill, those studies were done with chlorothalidone rather than hydrochlorothiazide. So it's a real mystery to me, even to myself, why I don't use chlorothalidone more often, except it might be a little bit more difficult to find in some pharmacies. It's actually the preferred hydrochlorothiazide medication to help control blood pressure.
Okay, great. Thank you. And how often should you check your blood pressure? More than once a day?
It depends on you, the individual. There are some patients who will check their blood pressure every single day. There are some patients who work in a doctor's office who can't even seem to get their blood pressure checked every single day. So the answer is it depends on what your blood pressure is doing and how comfortable you are with or without knowledge. So some physicians will recommend dogmatically every single day. If it's not going to give you any additional data, let's stop madness and just do the blood pressure check once a week, a couple of times a week, if that's going to give you the information that you need. If your blood pressure is rock stable, even at higher uncontrolled levels, it's just very, very stable, and checking it every day may not give you any more information and may just make you anxious because it's not exactly where it's supposed to be.
Good point. Okay, and the last one is going to be a combination question. It's actually a combination from a question in the Q&A and one that's in the chat. So in the Q&A, they would like to know, in addition to treating with meds, what lifestyle like diet, sodium, exercise, stress, etc. But I did see in the chat that someone had a question about any herbs that might help with medication. So if you could, that's more of a two-part, but you see how they're going.
Let me go to the first part. We did talk about it when I said advocate for yourself. And there is a slide on this. Advocating for yourself means participating fully in the conservative measures to help control high blood pressure. Controlling salt helps control volume, especially in the dialysis population. Salt control, volume control, alcohol control. So that's one alcoholic drink a day for women, which means heavy liquor rather than wine and beer. One alcoholic drink a day for women, 2 alcoholic drinks a day for men. Some people drink more than that. So restricting alcohol. Salt restriction, fluid restriction, alcohol restriction, exercise, preferably daily, optimally 5 times a week. Weight control or weight reduction. every 10 pounds of weight will reduce the blood pressure to some degree, as much as 5 millimeters of mercury. It is critically important for that. Okay, so those are absolute general recommendations for everyone. If there's other stress related things, if there's other stress reduction things that can be done, like prayer, meditation, those are excellent things. I did not show on the slide or mention that sleep deprivation can drive blood pressure up and can be a cause of hypertension. Our shift workers in the plants that we have in this area is often a major problem getting the blood pressure under control. So a good night's sleep, 6 to 7 hours a night at least, is important in keeping the blood pressure under good control. So by all means, everyone is recommended to pursue the conservative measures to control blood pressures, to reduce those blood pressures by 5, 10, or even 20 millimeters of mercury. So that's that issue. Herbs. It is very interesting with herbs. Nephrologists in general do not use or recommend any herbs because of the added issue with what they may do in interacting with medication, specifically in the transplant population. So as I have taken a family member through the whole transplant process and have visited with other nephrologists, not in my area, not in my practice type of setting, it is a fairly common practice not to use herbs at all. Many of the herbs that are out there have very similar names, and one may be okay, and another or the very similar name can do absolutely the opposite of what you think the herb is doing. I read an article on this, and the names that were given for the herb sounded so similar that I would absolutely get the name mixed up and then cause a problem. So we do not recommend herbs as a general rule.
Okay, super. And we do have just maybe 2 minutes left. Someone did ask a good question that I wanted to bring up. It was in the chat. And they wanted to know, do you have any recommendations for someone who has reacted adversely to blood pressure medications?
Oh, it's a very, very, very difficult issue. And let me just say, as a practicing nephrologist, it is the most challenging patient to get the patient who does not respond well to any of the popular meds that I put up on the board. And those are really the very, very common meds used at this time. So what I generally do is go back to old world medications. When I say old world medication, prior to being a physician, I was a pharmacist, and there are medications I use from the 80s and try to have the patient use those medications. So in this particular case, the conservative measures are very, very, very important to follow critically. Weight has to be at the ideal body weight. Salt restriction has to be maintained. Exercise really, really does help. And so I utilize those things, but in a person who cannot tolerate meds, thought always has to be less is more in this case. So the less medications I use to help the patient, the better that patient is going to be, because they're not going to tolerate medications in general.
Fantastic. Thank you very much. Lori, would you like to take control again? Are we going to do the raffle now? Dr. Godnich, thank you for your expertise. As always, Renal Support Network is thankful that you are willing to spend your time and expertise with us, and you're always a joy.
Well, thank you for inviting me. Again, sorry about the slides, and next time that won't happen.
Hey, it's happened to Facebook. If it happened to us, we've arrived, right? And Dr. Godnich gave a great presentation on kidney talk. So if you will I forgot the title of it. I think I'm a little fried in the
My
brain.
blood pressure is through the roof. What to do?
Yes, but you gave a podcast that
Oh,
a
podcast.
it was on
Pain medication.
pain medication. So if you want to get any presentations, just type her last name in our search function, and it will pop up on our website. And thank you, Dr. Godnich, so much. You're so knowledgeable. Cher's so lucky to have you.
Thank you so much for
Love our
having me.
nephrologist, that's for sure. And a shout out to our corporate mission partners for making this happen.